Welcome back to The Explainer. So, picture this. You're on a super busy clinical floor, the monitors are chiming constantly in the background, and an attending physician abruptly hands you a freshly printed EKG. What do? Well, seasoned medical professionals know you never, ever just stare at the paper and try to guess the squiggles. No way. You need a bulletproof, systematic approach to make sure you literally don't miss a thing. And today, we are mastering that exact approach.
Okay, let's dive into this. Here is the exact roadmap we'll use today to build your system. First, the 5-step EKG blueprint. 2, decoding rate and rhythm. 3, the 2 thumbs axis method. 4, mastering the EKG intervals. 5, morphology, hypertrophy, and ischemia. And finally 6, high-yield arrhythmias. Let's get to it. All right, starting with section 1, the 5-step EKG blueprint.
I really want you to anchor this 5-step checklist in your mind. The steps are rate, rhythm, axis, intervals, and morphology. Going systematically through this exact sequence is absolutely non-negotiable. Seriously, even if an EKG looks perfectly normal at a quick glance, or, even if a massive glaring abnormality jumps right off the page at you, you must force yourself through these 5 steps. Discipline prevents disaster. Keep that in mind.
Moving right along to section 2, decoding rate and rhythm.
Okay, so you need to calculate the heart rate rapidly, right? You want to use mental math without getting bogged down trying to count all those tiny little boxes. If the heartbeat is regular, just find the number of big boxes between 2 QRS complexes and divide 300 by that number. So say there are 4 boxes, 300 divided by 4 gives you a neat rate of 75. Easy. But what if it's irregular? Well, you can't use the box method. Instead, you're going to count every single QRS complex across a standard 10-second rhythm strip and just multiply that number by 6. Boom, you have your beats per minute.
Now, what's really interesting about this slide is that checking rhythm isn't just about noting if the beat is steady. By checking these specific markers, like is there an upright P wave in lead 2? Is there a P wave before every QRS? And is there a QRS following every single P wave? You are actively confirming that the electrical signal is actually originating from the normal sinus node. You're verifying that your primary pacemaker is doing its job.
Section 3, the 2 thumbs axis method.
I literally want you to use your hands for this right now. Go ahead, hold them up. Make your left hand represent lead 1 and your right hand represent lead 2. Now look at the QRS complex on the EKG. If the QRS is upright in both leads, give it 2 thumbs up. That's a totally normal axis. If lead 1 is upright but lead 2 is negative, so that's your left thumb up, right thumb down, that's left axis deviation. And if lead 1 is negative but lead 2 is positive, left thumb down, right thumb up, your right thumb is literally pointing the way to a right axis deviation. It is honestly that simple to visualize.
All right, section 4, mastering the EKG intervals. Now, intervals are where the hidden timing issues of the heart's conduction system really show up. You need strict mental buckets for these normal ranges so you can instantly spot when a signal is stretching too far. The PR interval should be between 120 and 200 milliseconds. Think of that as just 3 to 5 small boxes. The QRS complex, that needs to be tight and narrow, under 120 milliseconds, which is less than 3 small boxes. And for the QT interval, a super helpful visual rule of thumb is that it should be less than 50% of the distance between 2 R waves. If it's stretching past that halfway mark, you're looking at a prolonged QT.
Let's move to the next concept and see how this builds, because this is what happens clinically when that PR interval starts to stretch into various AV blocks. If the PR is consistently longer than 5 small boxes, basically 1 big box, you have a first-degree block. Now in second-degree type 1, the PR gets progressively longer and longer and longer until, oops, a QRS is dropped. In second-degree type 2, the PR is rock steady, it's consistent, but then you just randomly drop a QRS. And in a third-degree complete heart block, the P waves and the QRS complexes are completely disconnected. I mean, they are marching to the beat of their own completely separate drums.
Section 5, morphology, hypertrophy, and ischemia.
We've arrived at the final and probably most complex step, morphology. But before we actually look at the wave shapes, we need to know exactly where we are looking. So here is a punchy, slightly absurd, but highly memorable mnemonic taught by medical students to map out the heart's geographic regions. Ready? Big lie, little I, ass backwards, all.
Okay, let's decode that mnemonic by taking the key first letters to spell LISA. L stands for the lateral leads, 1, AVL, V5, and V6. I is for inferior leads, V2, 3, and AVF. S is for septal leads, V1 and V2. And finally, A is for anterior leads pulling from V3 and V6. You've got to memorize this mapping. That way, when you spot an abnormality, you know exactly which physical region of the heart is suffering the damage.
And this brilliantly illustrates the crucial visual difference when you're examining T-wave inversions. See, when a heart has ventricular hypertrophy, it causes these repolarization abnormalities. Just look at that strain pattern on the left. It's a slow, gentle, almost sloping curve. Contrast that with the ischemic T-wave inversions on the right, which are sharp, pointy, and deeply symmetrical. Knowing this visual difference is absolutely crucial. It helps you separate a chronic, benign strain pattern from a really dangerous, active ischemic event.
Now, when looking at QRS morphology, really wide complexes often indicate bundle branch blocks. For a right block, you want to look for that classic rabbit ears shape or RSR prime pattern right there in leads V1 and V2. But for a left bundle branch block, use this highly tactile imagery. Look for what one student famously called a deep caret S wave, plunging way down in V1 and V2, and that's usually paired with a broad, kind of clumsy-looking R wave over in V5 and V6.
Let's move into our final section, high-yield arrhythmias.
Utilizing this whole 5-step framework is how we identify the absolute do-not-miss pathologies. Take premature beats, for example. They are incredibly common on the telemonitor, but you must distinguish where they're coming from. A premature ventricular contraction, or PVC, is wide, it looks completely bizarre, and it completely lacks a P wave because it's firing erratically from the ventricles. On the flip side, a premature atrial contraction, a PAC, fires early from above the ventricles, so the signal actually travels down the normal pathways. Because of that, it has a narrow complex that looks very much like a normal QRS, it's just showing up way earlier than it should.
Let's rapid fire through some of these can't-miss visual buzzwords. For a STEMI, look for those classic tombstoning ST elevations. For a pulmonary embolism, you want to check for the famous S1Q3T3 pattern. That's an S wave in lead 1, a Q wave, and an inverted T wave in lead 3. Now for potassium issues, hyperkalemia gives you these dangerously sharp peaked T waves, while hypokalemia results in flattened T waves or even the sudden appearance of a U wave. So the crucial point here is that recognizing these exact morphological patterns will literally save lives on the floor.
Well, we've covered some incredible ground today. From the simple mental math of calculating rate, to the tactile thumbs up for determining axis, all the way to the precise morphology of ischemia and blocks. But let me leave you with this challenge. Next time an attending abruptly shoves an EKG into your hands while the alarms are ringing, what are you going to do? Are you going to just stare at the paper and guess the squiggles? Or will you command the room by deploying this 5-step framework? Like we said earlier, strict discipline prevents disaster. The choice is yours. Thanks for joining me on this explainer, and I'll catch you in the next one.